Dr. Demetrio J, Aguila III. I'm the host of the Direct Care Movement podcast, where we focus on the intersection between money and medicine and dive into a lot of questions that you've wanted to ask, or maybe you didn't know you wanted to ask until you actually ran across this podcast. And either you didn't know who to ask, you didn't know how to ask, you didn't know if you could ask. That's typically what we talk about on this podcast. And as those of you who have watched other episodes already know, typically we have a guest on this podcast that I interview. Well, this podcast episode is going to be a little bit different. Today it's just going to be me. And I want to share some of my thoughts on some recent events that have happened here in the United States. I know we have some international listeners as well. And so I'll give you some background information for those of you that aren't familiar with the situation, so that you have context for the rest of this conversation. So as many of you may already be aware, Brian Thompson, who is now the former CEO at United Health, was killed. He was killed on his way to a meeting, and it seems that based on the information that we have available to us now, that this may have been motivated by a lot of frustrations regarding healthcare, the delivery of healthcare, and the finance of healthcare. Based on the information that we have, it looks like there may have been one person who was really frustrated. Frustrated is probably not strong enough a word. I can't think of the right word for it, but was driven to take Brian Thompson's life because of how he felt he was being treated or mistreated by United Health. Now, let me start by saying Brian Thompson's death is a tragedy, period. It is a tragedy. The man was married. He had children. That woman no longer has a husband. Those children no longer have a father. They don't have anybody that's going to come home at the end of the day and say, "Hey, I'm home." That's horribly tragic. What's also tragic is that somebody was so frustrated and fed up with the system that he felt it necessary to take somebody's life about it. It didn't have to be this way, but it points to a larger problem. The death of Brian Thompson is a tragic event in itself, but what's even more tragic is that it's the symptom of a much deeper situation, a big problem, which in some ways is of our own making. Now, I know that that's not popular. It's not popular for me to say that, particularly to a group of physicians. And I know that the majority of the physicians, or the majority of the people that are listening to this podcast are fellow physicians, or are physicians in training, or are people who are hoping to be physicians someday, medical students, and maybe even people who are thinking of applying to medical school. And so I know that my statement that our situation is in some ways the result or the fruit of our own decisions is not popular, and it's not going to be well received. But bear with me and hear me out for a minute here, okay? Some of you may be aware of my background, and some of you may not, and so I'll give you the context for that. Okay. I've been working in healthcare since I was 10 years old, and that's not a joke. That's not an exaggeration. Okay. My dad is a retired physician, and I started when I was 10 years old emptying trash cans and scrubbing toilets in his office. And by the time I graduated from high school, I had done every job there was to do in a physician's office except be the physician. And at the age of 14, I was my dad's billing manager. I ran the billing. Now, imagine that, okay? As some of you may know, I've spoken about some of my colleagues who run insurance-based practices, and I have a colleague who is in a solo practice, and he has 11 billers and coders working in his office, 4 of whom are dedicated just to managing Medicare claims. And then the other 7 are dedicated to dealing with commercial insurance, prior authorizations and denials and all that other stuff. How could one 14-year-old person manage what takes 11 people to do now, 11 adults who have lots of specialized training and expertise in this area? Well, the answer is that healthcare was a lot simpler, or at least the finances of healthcare was a lot simpler. And it can be again. The situation that we find ourselves in today with health insurance companies is the result of a bunch of physicians who made the decision to offload responsibility and to give that to a third party and say, you know what, I'm just going to practice medicine and I want you to handle the business. Now, in defense of the people who have been handling the business, they've been doing what they know best, the way that they've been trained to do it. But they're not physicians. And physicians often would make different decisions when it comes to running a medical organization than non-physicians would. And I think physicians are particularly well suited to be the ones in the driver's seat making those decisions because we have the best sense of which compromises are going to yield the best results for the patient. Okay. As an example, if I'm trying to save money in my practice, I'm willing to make compromises on which, what kind of bandage I'm going to use. Company X might make a Band-Aid that, that works better and costs less than company Y. But I'm not going to cut corners on meds. I'm not going to say, well, if we use half as much local anesthetic, we can save some money. Well, my patient's going to be a lot less comfortable during the procedure. As a clinician, as a surgeon, I'm particularly well suited to make those decisions about where we should be saving money and where we should be investing money. When physicians as a group decided, you know what, I don't want to be involved in business decisions any longer. I want somebody else to make the business decisions. What they did was not only did they offload the workload associated with that, but they also offloaded the power to make decisions. They gave somebody else responsibility for deciding where can we cut corners and where should we not. And so that landed us in a position where we have a whole bunch of bureaucrats who aren't healthcare experts making decisions about where money should be spent in healthcare. Okay. Now, I want to back up a little bit. When I was 14 years old and I was my dad's billing manager, I remember very distinctly what I had to do. I can, if I close my eyes, I could still see the physical ledger cards that my dad had ledger cards, and he had this ledger system. And all I had to do was take the ledger card for the patient and write in one line, patient visit, $20. And then write in the next line, patient payment, $20. And then in the final column, balance, $0. And that was it. That was my entire job. Okay. And this is before the widespread use of health insurance. Health insurance didn't have much say in whether or not a patient got care, didn't have much say in whether or not the cost of care was going to be this much or that much or whatever. The doctor decided this is a reasonable price. The patient agreed that it was a reasonable price, and the patient paid for the care. Now, I remember when things started to change, because a growing number of patients started coming to my dad and saying, "Hey, doc, I have this health insurance now from my employer." He says, "Okay, I don't know what that is." He said, "Well, the nice thing about it is that, when you give me the receipt for the care that I got, I submit that to the insurance company, and then they reimburse me for the visit today." He said, "Oh, well, that sounds great." And so at first it seemed like a really good deal. But then what happened after that was that, my dad, being a nice guy, some of the patients would come to him and say, "Doc, I know that the visit today cost $20. I don't have $20, and today is, today's Tuesday, and I don't get paid until Friday. So can you do me a favor and just give me the receipt for today's visit as though I paid it? And when the check comes from the insurance company, I'll just sign that check over to you. And my dad, being a nice guy, said, sure, no problem. You're a nice guy. I'll trust you. And thankfully, the majority of the patients did exactly that. When the reimbursement from the insurance company came, they signed the check over to my dad. And I know this because I remember I was responsible for tallying all the deposits also. So I'd have to put that in the envelope to be deposited later on that day. And I would see these checks, which were endorsed from the insurance company to the patient, and then from the patient to my dad's practice. But unfortunately, there was a small number of patients who abused my dad's trust. It was a small percentage, but enough to start to hurt the bottom line. And so my dad was really frustrated with this, and he didn't know what to do about it. Until he heard from some of his colleagues. He said, on that insurance form, there's a little box where the patients can sign. And you should have every single one of your patients sign that box, okay? And that box is called the assignment of benefits box, all right? Now, for those of you who have received health care here in the United States at some point in the last 10 years, when you go to the hospital, you go to the doctor's office, they always have you sign a bunch of forms. One of the things that you have to sign is the assignment of benefits, okay? Now, some of you may know what that is, but I imagine some of you don't. And so I'll explain that. The assignment of benefits section says that after the doctor submits the bill, okay, and the doctor's the one submitting the bill. Originally, as we talked about, the patient would submit the bill and the receipt to the insurance company, and the patient would get paid because the relationship that the insurance company had was with the patient, not with the doctor. Okay. But then what ended up happening was that, again, a growing number of doctors started getting stiffed by by a small number of their patients. And they said, we need to do something to address this. And so there was that assignment of benefits section. And so basically what happens when you sign in that assignment of benefits section is you tell the insurance company, don't pay me, the patient, pay my doctor directly for today's visit, okay? And I'll allow the doctor to submit the bill on my behalf so that I don't have to deal with all of that paperwork, right? Now, at first blush, that sounds like a really great idea, right? The patient doesn't have to deal with the paperwork. The doctor doesn't have to deal with wondering whether or not the patient's going to sign the check over. Everybody wins, right? But there's an unintended problem with that scenario, okay? And I'm sure nobody intended it for it to turn out this way, but this is where we ended up, okay? Before the advent of the health insurance in my dad's practice, the relationship was strictly between my dad and the patient. And my dad would say, this is how much the visit costs, and the patient would agree, and that was it. It was done. They knew in advance, this is how much it's going to cost. They knew the quality of the care they were receiving, so there was a value proposition. The patient saw the cost and the quality and was able to determine, this is how valuable this is to me, and I'm willing to invest that kind of time and energy and money into that. With the advent of the assignment of benefits section that the patient would sign, the patients were then disconnected from the cost of care because the patient never saw what the cost was going to be because the bill wasn't presented to the patient. The bill was presented directly to the insurance company. And since the insurance company didn't send any of that paperwork to the patient, but instead sent the check directly to my dad, the patient now had no idea how much the care cost. And eventually what ended up happening was that the patient said, well, I just show my card and I get my care. And they felt like it was for free. Okay. Now, how much does the average American value something that they get for free? About that much, right? And I mean, that's just human nature, right? So what ended up happening? I think at first my impression was that this worked out okay for most doctors. They said, oh, thank goodness, I don't have to worry about getting paid, and the patient doesn't have to deal with the hassle of the paperwork. We'll just offload that for them and we'll all be good. But what ended up happening was that a small number of unscrupulous doctors started to abuse the system, and they said, well, I used to charge $20 for these visits, but I mean, who's it going to harm if I send a bill in for $100 instead? I mean, the patient doesn't have to pay $100 anymore, so I don't have to worry about hurting the patient. So I'll just send in a bill for $100 instead of $20. And when enough of that started to happen, the insurance company said, well, wait a minute, now we're being abused. We need to do something to protect ourselves from this kind of abuse. So they started introducing mechanisms for making sure that the care that was being provided was appropriate and the charges were appropriate. Well, that meant doctors were getting denied, right? They were getting denial. So the doctors had to implement mechanisms to either prevent or fight the denials. And so you see this arms race in between the insurance companies and the people who are providing the care, those of us in the trenches, right? Where you introduce more and more administrative mechanisms to get around the administrative roadblocks that the other side has put up. And we end up with where we are today, with this big monster healthcare system where so much of the cost is associated with administration, whether it's administration on the doctor side or whether it's administration on the insurer side, all of which has been put in place to try to get around the obstacles that the other side has put in. So that brings us to Brian Thompson. Why is there such frustration dealing with healthcare and health insurance? Because we as physicians have allowed ourselves to be involved in a system which has introduced all of these mechanisms so that we wouldn't have to be involved in decision making on a business side. How many times have I heard physicians say, well, if I didn't have to do, all these prior authorizations, I didn't have to do all these appeals, I didn't have to deal with this, that, and the other thing, it would be so much better. I'd love to be able to just deliver care. Well, imagine if you could take a small portion of the amount of time that you spend on prior authorizations and on appeals, and then all the other mechanisms that are in place to minimize that, like your electronic medical record system. Think about how much money you spend on your electronic medical record system and how much of your electronic medical record system is built around making sure that you can code and bill appropriately and get paid appropriately and in a timely fashion. And do you get paid in a timely fashion? Do you get paid the same day as the service? Like, when I go to McDonald's and I get a cheeseburger, when does McDonald's get paid? They get paid the same day, right? How many of you working in an insurance model get paid the same day that you render the service? I would venture to guess none, right? So you're frustrated. Okay, you're frustrated by all the boxes you have to click on your electronic medical record system so you can make sure that you've met all the criteria to be able to code at a 99214 or whatever it is you want to code, or that you dictate or type up your report for surgery in such a way so that you can make sure that that CPT code is justified by the content of what you did so that you can get paid or denied or have to deal with an appeal at some point down the road. I mean, there's all kinds of frustrations. Think about all the time and energy and money that you spend dealing with all of that. If you could take a small fraction of that and use it to run the business of your practice, but get rid of all that other administrative stuff, wouldn't that be a better compromise? There's a solution to a lot of this frustration that people are feeling. And it's called direct care, whether it's direct primary care or direct specialty care. Because direct care involves transparency, and it involves putting the patient back in the driver's seat, letting the patient decide whether or not to take on a particular treatment. Just like in my dad's practice. The patient knew that she had a problem. My dad offered a solution. The patient said, okay, this problem is worth $20 to me. I'm willing to pay $20 for this problem. My dad said, well, my time and my expertise are worth $20. Let's shake hands and we have a deal. That model existed before the advent of widespread use of health insurance. That model exists today in the form of direct primary care and in the form of direct specialty care. This is not just theoretical. The model exists today. We can restore the doctor-patient relationship. We can put the patient back in charge of making decisions about whether or not to get surgery X, or whether or not to get such and such a blood test or a CT scan, or to undergo a stress test, or whatever the case might be, whether it means going into a doctor's office or going into a lab or into an imaging center or a surgery center. These options exist. The frustration that surrounds healthcare does not have to exist. Most of it can be addressed by mechanisms that are already in place. But the challenge that we face today is that so many of us, all of us, myself included, have been trained to believe that the only way you can do things is through the insurance model. So much so that people now think of it as the traditional model, when the reality is that the traditional model is direct care. For centuries, direct care was the way medicine was practiced, and it worked. Now, some of you might argue, oh, well, medicine's so much more complicated now than it was back then. On some level, that's true. But I'm a subspecialty surgeon, okay? Depending on the problem that patients come to see me for, there may be 6 or 7 of us in the entire country that can take care of that problem. I'm so subspecialized, okay? And so you could argue, oh, yes, that's an example of how complicated medicine has become. And yet, my practice is a direct care practice, which has simplified the things that should be simple so that I can focus on the things that are complicated. It's fair. It's fair to the doctor. It's fair to the patient. It's fair to everybody involved. I can't presume to tell a patient how much his problem is worth to him or her. I can't tell somebody who's had multiple spine surgeries, who continues to have pain, how much his pain bothers him. I don't have the ability to do that. But what I can do is tell that patient, this is what my time and my expertise are worth. It's up to you as the patient to decide whether or not your problem is worth the same thing. And because we have a direct care practice, we can offer transparency up front. The patient knows what they're getting themselves into, both from a medical standpoint as well as from a surgical standpoint. I don't know the specifics of the frustrations that surround this case, but I do know a lot of patients who are frustrated by very similar situations and very similar roadblocks that they faced in their care. I can also tell you that in our practice, many patients are very nervous when they first come in about the fact that it's a direct care practice. But by the time they walk out the door, they realize this is valuable. This is what value looks like. This is how I can make an informed decision about whether or not I want to take on that cost. Just like buying a house, just like buying a car. Okay? A lot of people will say, well, healthcare is too important. It's a necessity. You can't introduce price transparency because patients might decide against moving forward with a particular kind of treatment because they're intimidated by the cost. You can't tell them. It's unethical to tell them how much it's going to cost beforehand. I've heard people say that. Doctors have said that to me before. And what I would say to those doctors, and some of you are listening right now, is would it be acceptable to go into the grocery store, take home a gallon of milk, and then wait 6 months to find out whether or not that gallon of milk bankrupted you? Or would it be more acceptable to know how much that gallon of milk costs before you walk out of the grocery store and consume it? Would it be acceptable to move into a house and only find out a year later that you can't afford that house and you now have to declare bankruptcy in order to be able to pay for what you've already used? Or would it be more acceptable to know beforehand what the price of that house is so that you can decide whether or not you actually want to purchase it? I would argue that food and housing are more immediate necessities than any healthcare that I would provide, and with the exception of certain types of trauma and maybe certain types of cancer, that applies to just about every healthcare decision. And yet, some people argue that it's not ethical to know beforehand how much it's going to cost. I would say that's a misinterpretation, a misunderstanding of the truth. The reality is that patients deserve to know what they're getting themselves into. And much of the frustration that revolves around healthcare these days revolves around that very question. I don't know what I'm getting myself into. I don't have a good sense of how this is going to impact me. Maybe I have a good sense of how it's going to impact me from a medical standpoint, but not from a financial standpoint. So how can I make an informed decision about whether or not this is actually worth my time, my energy, my resources? That's not fair. And if you compound a whole bunch of unfair situations, you put them all together, it leads to a lot of frustration. And maybe, just maybe, it led to the kind of frustration that ended up in Brian Thompson's death. There is a solution. There is a better way. We as a nation can decide that we can do things better. And in certain pockets of the United States, we're already seeing this. You can look at the Surgery Center of Oklahoma. You can look at the Texas Free Market Surgery Center. You can look at Renovo Health in Wisconsin. You can see the work that Matt Ort has been doing with Self-Fund Health. You can take a look at the Free Market Medical Association. You can see all kinds of examples. Veritas Surgery in Idaho. There's an endless list. It is possible to do things better because it's being done better. It is possible to remove much of the frustration and anxiety and cost associated with the problems in our healthcare system because it's already being done. But for those of you who are physicians in training or physicians to be, it's up to us, you and me. It's up to us to take these mechanisms, which already work, and to make them widespread, to make them widely known, so that fewer and fewer and fewer people have to find themselves in these situations where they feel like taking somebody else's life is the only answer. We can do better. We are doing better. But those of us in the direct care movement, we need your help. We need the help of every physician out there. We need the help of every employer out there. We need the help of every single American to make what we do mainstream rather than something that only that person gets the benefit from or only that person gets the benefit from. It's been shown that this model works, that it helps more people, and it can do it more affordably. Patients can get better care. They can do it at lower cost. They get greater value from the situation. And doctors have more satisfaction in the work that we do because we know we're making a difference on multiple fronts. We're making a difference on a medical front, and we're also making a difference on the financial front. Because ultimately, I would venture to guess that the vast majority of us, maybe close to 100% of us, went to medical school because we wanted to make a difference, and we thought that we actually could make a difference. Well, we are facing a new challenge. Unfortunately, it's one largely of our own making or of the making of many of our predecessors. But we can overcome this challenge. We as physicians have the solution staring us in the face. We can overcome this challenge. We can do better. We can offer a better proposition, a better solution, a better value proposition to our patients, and a better value proposition for ourselves. And so this is my call to action for every single one of you out there. If you're already doing primary care or specialty care, which is direct, which is to say you're either in a direct primary care practice or a direct specialty care practice, congratulations, because you are offering the solution. For you, I would ask you to spread the word. Be an evangelist. Tell your friends and colleagues and show them, more importantly, show them how it can be successful. For those of you that are thinking about it, stop thinking and start doing. Join us and make this a reality for more than just a small percentage of Americans. And for those of you that are curious about it, but haven't really committed one way or the other, dig more deeply into these questions. Ask those of us that are already doing this. Listen to this podcast. Find other resources. Find other people who are doing this. Because we can prevent a lot of tragic deaths, whether it's deaths like Brian Thompson's or the deaths of patients who have been mistreated by the system. We have the power to do that. We just have to decide to do it. As physicians, as a group, we are some of the smartest people on this planet. And I refuse to accept the idea that we can't do better, because I know we can, because I've seen it happen. I've seen it work, and I know you can do it. I'm a surgeon, which means I have to make things simple so I can understand them. And if I can understand it and I can do it, then so can you. I would encourage you to take these words to heart, to think about them. For those of you that pray, pray about it. Ask yourself, how can I take better care of my patients and myself at the same time? And I think if you give it a lot of honest thought, you'll discover that for many of us, I would argue almost all of us, direct care is the answer to that question. Thank you for your time. Thanks for listening. And if there are other topics that you'd like to see us cover here on the Direct Care Movement podcast, please reach out. Reach out to me, reach out to the Influent Network. Let us know what you want to hear about, and we'll try to address those questions too. Thank you.